Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com and grab your free 31-page PDF. It's a great study guide or review on the top 200 drugs and things that I've seen in clinical practice, as well as things that often show up on board exams, whether you're a nurse, pharmacy student, med student. Great resource there. Simply an email will get you access to that. And then, of course, we'll also get you updates when we've got a new podcast available, as well as other new content. The drug of the day today is inhaled budesonide. And brand name of this medication is Pulmicort. And budesonide, I have covered this a little bit in the past. I've covered systemic budesonide use, but I haven't specifically focused on just inhaled budesonide. Now, it should be noted that it does come in other combinations. So Breztri and Symbicort are combinations of budesonide with other inhaled agents that are typically going to be used in asthma and COPD, for example. But I do see a fair amount of Pulmicort use on its own. And again, those indications, asthma, COPD. And with recent GINA guidelines, recommendations, we're seeing these inhaled corticosteroids used more and more in acute exacerbations and getting that steroid on board and obviously trying to prevent re-exacerbation and obviously help acutely with the situation as much as we can. But I'll talk about the onset and some of the pharmacokinetics a little bit later and why it doesn't necessarily work instantaneously, but I'll dig into that a little bit later. So let's talk about the dosage forms a little bit. So Pulmicort or budesonide comes as a dry powder, and that's called the Flexhaler is the device there. 90 and 180 micrograms per inhalation is the dosing there. And then we also have a nebulized formulation. And in practice, where I've seen the nebulized formulation used the most are pediatric patients and geriatric patients. So these are patients that can't necessarily coordinate the timing of their breath, or in maybe geriatric situations, maybe that breath isn't deep enough and strong enough to allow us to use the dry powder product. So you'll definitely see nebulized budesonide used in those patient populations. Now, the different dosing is laid out. So for nebulized formulation is 0.25 to 1 milligrams per 2 mil neb. And depending upon what we're trying to do and how aggressive we want to be, we can get to low, medium, and high dosing. Now, if you remember, this is laid out in asthma guidelines, low, medium, and high corticosteroid dosing. Pearls.com/RLP. If you create a free account there, you can get an awesome chart that lays out all those different strengths and what category they fall in. I know this is definitely something generally in more advanced pharmacology board exams that might come up, but just understanding and recognizing what category of aggressiveness they're in, low, medium, or high, based upon the drug we're using and the dose we're using. So, for example, Pulmicort, dry powder, flex inhaler, per GINA guidelines. So low dose would be considered 200 to 400 micrograms per day. Medium dose would be considered anything above 400 micrograms to up to 800 micrograms per day. And high dose would be considered above 800 micrograms per day. So I think that kind of lays that out a little bit. And again, that reference, Pearls, PYRLS.com/RLP. If you haven't taken advantage of that, they've got a free chart that you can have access to once you create a free account there. So definitely go take advantage of that. So mechanistically, I'm not going to go through this a ton. It's an inhaled corticosteroid, has glucocorticoid activity, ultimately reduces action of things like leukocytes, which reduces inflammation. And if you remember, this is one of the primary issues in asthma, is that kind of hyperactivity, hyperinflation, inflammation, issue in asthma. Administration. So one important thing for all inhaled corticosteroids are we're going to want to rinse. So rinse and spit after use, and that's to help prevent infection, thrush, things like that. There is a couple things I wanted to mention specifically with each of the two major products. So the Flexhaler, it does need to be primed, but it only needs to be primed the very first time the patient uses it. Okay, so you don't obviously, if they take a dose and then they skip a day, it only needs to be primed that very, very first time. So one-time priming only. And then being a dry powder device, we do not shake the Flexhaler. Okay, so many patients are used to doing that with an albuterol inhaler or something like that, where you got to shake it. This should not be shaken. Now the nebulized formulations, let's mention them a little bit. Probably one of the biggest questions I get asked are, can I mix nebulized formulations? So two of the big ones, most common ones, albuterol and ipratropium. There is some evidence supporting that mixing these is okay for delivery. So I would definitely refer you to look at your organization's policy and procedures and what's allowed and not allowed. But if you do go look at the literature, there is some evidence to support that mixing is okay. It's not going to harm the patient, and they're going to get the drug there as well. Adverse drug reactions, upper respiratory tract infections, thrush, those are two risks associated with inhaled corticosteroids like budesonide here. So local irritation, cough, things like that can happen as well. And another question I get from patients generally after they've done some research online is, should I be concerned, whether it's, pediatric patient or, risk of osteoporosis, thinking about some of the issues with systemic long-term corticosteroid use. Do I need to be concerned about those issues? And, the risk of issues is extremely, extremely low because the percent absorbed systemically is extremely, extremely low. With that said, it's something to think about for sure. Adrenal suppression, elevated blood sugars, osteoporosis, insomnia, immunosuppression risk. Those are risks that are going to be generally more associated with longer-term corticosteroid use, where we're using those systemically, not necessarily inhaled. So again, not to say that it absolutely cannot happen, but the risk is extremely, extremely low there. Flexhaler, I did want to mention, also contains lactose. So there have been reports of anaphylactic reactions to that. So definitely pay attention to that if you know somebody has had an issue with that. Monitoring parameters, obviously we're using this for respiratory conditions. That's what we're going to be monitoring. So your FEV1, your peak flow, other kind of pulmonary function tests as well there. And then I wanted to mention kinetics. So I kind of alluded to that earlier. How quickly does this medication start working when we use it for asthma and COPD and things like that? So it takes definitely at a minimum hours, more likely days to really begin working and show its effects. So that leads to an important patient education point for sure. We got to make sure that patients understand that this medication does take a while to work. So if they take one dose and they don't feel any better within 15 minutes, half hour, that's what's supposed to happen. It's supposed to take a little time to work, and that's okay. So we have to do that patient education so they don't take a dose and hour later, I'm not breathing any better. This medication's junk. So I've had to have those conversations with patients in the past who have quit taking their inhaled corticosteroid. So really, really important patient education point to ensure that patients are actually getting the medications that we are prescribing or dispensing or administering them to them as well. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for pharmacist board certification study material like BCPS, ambulatory care, geriatrics, go check out meded101.com/store, S-T-O-R-E. In addition, if you're a student, whether that be nursing, med student, we've got tons of books, case studies, food-drug interactions, drug-drug interactions, all sorts of goodies on Amazon that can really help you become a better healthcare professional. So go check that out. All your support through the links at meded101.com/store obviously help support this podcast and keep it free for all to benefit from. So greatly appreciative to those of you who have shared some of your income with us to help keep this podcast going. All right, let's wrap up with drug interactions. So there aren't a ton, which is nice, and we don't have a ton of systemic absorption with this drug, budesonide, inhaled budesonide specifically. So that's not a major concern in my mind as far as drug interactions, but there is a couple things I think of note that we should pay attention to. So CYP3A4 inhibitors, definitely not an absolute contraindication, but they can potentially raise systemic concentrations of budesonide. The other interaction that I did want to mention, something that I look out for, is infection risk. So, thrush, upper respiratory tract infection, that risk is potentially elevated a little bit with the use of an inhaled corticosteroid like budesonide. In normal immunocompetent patients, I don't really worry about it a ton, but if you get patients that are immunosuppressed, that might just be one more thing that kind of tips the scales toward them being more at risk for an infection to happen. So any type of transplant patient that's on, significant immunosuppressives, a lot of patients with autoimmune diseases may have other immunosuppressives on board. So those are situations where we may have a little bit more heightened risk for various types of infections. So again, something we're going to monitor, and if patients are having frequent infections, obviously we've got to kind of weigh risk versus benefits of the medications that we're utilizing that could potentially suppress that immune system and increase the risk for infection there. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. Don't forget to support the sponsor, meded101.com/store, S-T-O-R-E. If you enjoyed this podcast, found it beneficial, share us with a friend, leave a rating, review on iTunes or wherever you're listening. Go subscribe at reallifepharmacology.com. Get that free 31-page PDF. And, of course, support our sponsor today, Pyrls.com as well. So PYRLS.com/RLP. Go sign up and get your free chart on the inhaled corticosteroids. If you want to reach out to me, got suggestions, comments, concerns, mededucation101@gmail.com. Otherwise, you can find me, Eric Christensen, BCPS, BCGP, on LinkedIn. Thank you so much for listening, and I hope you have a great rest of your day.